Okay, thank you very much. A great discussion at the level of the states, and it adds a very important level of insight into taking this down another level. I really appreciate these three presentations. So at this point, we've got the opportunity for comments and questions, and Andrew, you look like you're ready first, so go ahead.
I am ready, because I just want to take a minute to thank all three of you and your colleagues.
Could you come closer to the microphone?
I just want to take a minute to thank all three of you and your colleagues back where you work, because you voluntarily participated in the process to create the case studies for the commission paper, and words might not suffice, but it's what I can offer. So thank you, and you really are stellar examples of how health literacy can be put in place across the country.
Very appropriate comment. Right up here.
Yep, Pat McGarry, Roundtable member, and I echo Andrew's comments. So thank you all for sharing. It really kind of puts substantive examples into action, and you really would be commended for doing your work at your state level. Susan, I have a question for you regarding the BRFSS. I think it's fantastic that you have state-specific questions, and I'm curious as to find out. And I'm also from Kansas, howdy neighbor, and we don't have any eyes either, though I'm from Illinois, but that's another story. Currently live in Kansas, so thank you for sharing that information. I also noticed that the Kansas Secretary of Health pointed out this is National Health Literacy Month, so it's kind of
October.
It says in Kansas it's November, but that's
we
have a health literacy disconnect here. But when I was in Illinois, I served on the BRFSS Data Use Committee, and we created state-specific questions. So I'm curious as to find out how you formulated these questions, which I think are excellent, by the way. Thank you.
They're not, we didn't formulate the questions. They came out of the research. Chu, and I need my notes so I can remember. There's Chu and Wallace, yeah. And I'm going to now need
Well, I'm looking at, how confident are you filling out medical forms yourself?
Yes.
Yeah. And
Yeah, and actually, and these questions are slightly revised because Kansas actually, we found out in June, Kansas did this a year ahead of us, okay. And are going to, and Kansas is doing it again this next round. And so we went ahead. We had initially thought we could only get one question. We sort of started with. We dreamed small, but when we realized that we had a neighboring state, just geography lesson, Kansas and Nebraska are next door neighbors, we decided that we would go with, we would use the same questions that Kansas did so that we would be able to sort of have the strength of that additional state's data. I'm sorry, and what did you, the rest of your question?
Well, I think I just want to know the origin of the questions, and
yeah.
That's been answered. And is this, I know states kind of repeat questions. Do you have a strategy on what longitudinally you plan on implementing these questions?
Well, this is being done through Health Literacy Nebraska, which is not a state. You know, we do have some people from the state who have joined our steering committee, but we are not a state organization. So we're basically, we are paying for the addition of these items this time around. And one of the things that we'll want to look at is, does this give us the kind of information that would, that we can either get the state to take it on as a regular basis, or that we would be able to find funding to continue to support having it be part of the survey going forward. But we are interested in both sort of what it tells us at a more granular level about health literacy in Nebraska, because we still, when I'm running across the state, we still run into this isn't a problem here, but also we want it to really elevate the idea that health literacy is one of these predictors of negative health outcomes, and all these other predictors appear on the BRFSS. Why isn't health literacy there? And I think by not having it there, it sort of contributes to the invisibility of the problem.
Well, thank you. And you would be commended for wise use of your resources.
And also up here. Go ahead.
The presentations were absolutely wonderful. And the strange thing about the term case study is that it gives the illusion that here's a unique experience that we can read about as a story. But actually what has happened in these case studies that you've offered is you really illuminated the pathway to integrate health literacy into the state. And I would love it if there's some mechanism for extracting those steps along the pathway that other states could take. You have it. You just have it beautifully. And there were two questions I wanted to follow up with in thinking about taking action. Do you think that either of these two actions are possible? And if so, how would we go about doing it? Or would you instead suggest a slightly different action? For example, number one, can we require that all employees of public health departments, whether state or local, take a small online course in health literacy, like, I'm not saying that it just has to be the CDC, like the one that the CDC has. Can that be required of all existing staff and part of the orientation for all incoming staff? That's one. Second, do you think it's possible to have a regulation that all contractors with departments of public health who are responsible for the design of websites and or the design of all materials and messages that go out must meet certain criteria about a suitability measurement, must meet and show evidence of criteria for development, i.e. pilot testing and changes made based on work with members of the intended audience? Could those regulations be part and parcel of every state contract?
I can answer that question from real experience. When I was in Kentucky serving as the Director for Health Equity, I reported directly to the commissioner. And so I worked hand in hand with him to try and change some of the policies that we had in terms of training for the staff there. And we also worked with Workforce Development Division. And so what I did was I created a webinar for people, but it wasn't specifically around health literacy. It was just about cultural and linguistic competency or health equity. So I tied those themes into it, and I put it on this tool called Train, which most public health departments have access to. And so staff would be required to take the webinar, and then we offered brown bag lunches to complement the webinar. So it really is about policy and working with your decision makers to encourage them to enact those kind of regulations for their staff, but also working with your human resources entities at your organization. I think that they're open to doing that in my case, but it did take some time to get to that point so that they could understand that. In terms of contractors, I'm not sure about state governments just because there is a lot of bureaucracy in there, but again, you would have to probably work with the people who develop those contracts on the health system side and requiring that. But I know with our tobacco-free living program, I have created a standard that if we're going to develop messages that are going to target people who actually smoke, we need to have input from diverse populations on the panel in developing the plan, because we've typically put out messages that where people and themes did not reflect the population we were trying to target, and as a result, we have very high rates of smoking. And so the policy we've enacted is to assure that our vendors and contractors have that kind of lens, that diverse perspective and focused lens. So I think it has to happen at the policy level, working with your leaders and decision makers to make that change.
Great.
Let me add to that. I'm not sure a mandate in either of those is going to be workable. I think it is good to make that training known and encouraged, the online training, but Arkansas being a poor state, we have some serious IT infrastructure issues. So, for example, we purchased 10 licenses to the Health Literacy Advisor software and made sure that at least one person in each region got them, but they couldn't use them because the computers and software are so old. they were incompatible. So that kind of thing is an issue. With regard to our website, there is a state agency that is not the health department that does the websites for state agencies. And it's difficult to, it was a challenge with the volume and the issues to have them address the things that we wanted, that actually one of our staff at the Office of Health Communications and Marketing taught herself HTML so that we could do it ourselves. So, and she's actually been part of the plain language learning community so that when she gets requests, for example, to put something on the website, she'll run a readability analysis and send it back. So and if we made that a requirement, I'm not sure we would have the expertise to implement it. So I think growing the expertise, and so that as things are developed from the beginning, and then asked to be put on the website, it's different than having someone police it or run it through a analysis and then send it back, and then people don't know what to do with it. So that's why we're trying this other approach.
Very helpful. Thank you.
But I also think that having that as a best practice goal is something that would be, and certainly in our context, would be very well received by the health departments. And, you know, having that as stated as a best practice would certainly be something that could be workable for us.
Great, thank you.
Hi, my name is Doğan Erol. I'm from CDC, from the Office of Associate Director for Communication, and I work with a colleague, some of you know, Cynthia Bauer, and she couldn't come here. She said, you really have to go and see and meet who's who in health literacy, and I'm glad I came. I would like to kind of summarize my view of the morning session from my perspective. When Dr. Pleasant gave his summary of the survey findings, and I will read the paper, I was worried. I said, is it that bad? And then some of the comments that followed that indicated that more was being done, but they were hidden. I was relieved, and when I heard the three examples from Louisiana, Arkansas, and Nebraska, I am encouraged. I think what Rima was suggesting maybe, but certainly making remarks related to that, it seems like we're at a point where there are great practices and tools, and they need to be taken to scale, and I'm glad I'm ending up with this note for my benefit. Thanks.
Thank you for that comment. Okay.
My name is Deb Schulten, and I'm the health director at Northeast Nebraska Public Health Department. And Susan is one of my colleagues and partners in crime. And I'm part of NALD, and I'm also part of Health Literacy Nebraska. And we just had the good sense when we had a resignation to hire Susan as our executive director of NALD. So I look forward to having her implement some of these things. In our health department, we started a health literacy project back in 2008. I had been interested in the topic since 1997. But if you look at our case study on Nebraska, you'll see that we really are just kind of in the toddler preschool period of public health as far as local health departments, because hardly any of the counties had health departments prior to 2000 and 2001. So only 22 counties did out of the 96 counties. So in my 4 counties, they thought public health was some new thing that the government thought up, and so, and a lot of the health directors, my colleagues, some of them had never heard of public health before either, and so you have to look at these very basic things, and so it's very interesting to hear in Arkansas that we have some more primitive practices out there and some of the barriers that are pretty significant that we have to overcome. we always require new employees to take online the Public Health 101 course and the Health Literacy course and all the NIMS courses for their public health emergency response preparedness. So that's just part of the orientation, but I think we really need to do a good job about spreading that around to the other local health departments. Thank you.
Great, thank you. Okay, so I have another question that's come in through the internet from Cindy Brock. And she's irrepressible. And her question, we've got two of them. First one is for Susan Bockrath. When Susan spoke about attribute number 1, she said they suffered from a lack of templates. I'd like to ask what kind of templates would help her organization implement the attribute.
Okay. I actually wasn't meaning to just say that for that particular attribute that we lacked templates. I was meaning more the template for specifically for health literacy policies for local health departments. I mean, I do think that there are a lot of templates that are out there for us to pull from and that are pretty good fits for what we want to do. I have a couple of health directors who've approached me wanting to know, like, what is a template for local health departments to have a health literacy policy? And I don't know that that exists, and perhaps I'm mistaken, and I would love to be informed otherwise right now.
Nobody's jumping up to
No,
correct you. Would that be useful to you?
Yes, that would be useful to our health directors because people are committed. The health directors in Nebraska are very committed to bringing health literacy into their health departments, to having it be not only something that they're teaching their staff about, but that's really integrated into their work. And I think that people don't have a whole lot of time to sit down and think about how do I make a policy from scratch, and so right now that's a piece that they've looked for and that they're missing, and that it ties in closely with their QI work as well.
So for Torrie and Jennifer, would such a template be useful for you too?
I'm not sure that a template would necessarily serve the purpose. I think maybe there has to be objectives that says, as an agency, we will address cultural and linguistic competency, or we will assure that people are part of the planning process. And then you go back and you say, well, did we include these people at the table? Did we market this to the appropriate population, and did it work? So I think it's more around not so much a checklist, but a process of making sure you do those things.
I guess there's lots of things that a person could mean by a template. Yeah. I mean, I think model policies could be helpful. I think model processes could be helpful. And of course, being the poor state that we are in Arkansas, we'd like to steal anything that we can from other states.
We steal too.
So I think that's not a bad idea, is to have the models that we could use to stimulate thinking and discussion.
I think your term model is more apt than template.
Okay, great. So from the irrepressible Cindy Brock, question number 2. For Jennifer, why as a Department of Health did you decide that training practices in universal precautions was a priority?
Well, we ran into this phenomenon where many public health providers, healthcare providers, see health literacy as a deficit in the patient and do not believe that they are miscommunicating and have great difficulty kind of seeing the system in which they operate. And we felt that the toolkit was a good avenue to look at things from the provider perspective, to allow providers, whether they're in a primary care clinic or a local health unit, to assess their practices and then look for evidence ways to improve them. So the idea behind the toolkit is to give them a way to do that. Of course, part of the toolkit teaches the plan, do, study, act cycle, which is much needed in the public health system as well as in the healthcare system. It's a simple exercise that clinics can do on their own if they will own the process. And so that's what we're trying to engage people in, because we know that many providers are frustrated in the current system and that there's room for improvement. And some of those improvements are not costly and they're not complicated to make. Some are, but some are not. And it's a way of kind of getting to the low-hanging fruit.
Great. Thank you very much. Rima?
Just very briefly, as a member of the planning committee for this meeting, very early in our notes, we articulated a strategic long-term plan, and we were hoping to build towards engagement with people in public health to perhaps look at this 10 attributes of a health literate organization, and already you've provided input, but to see what needs to be added or subtracted or modified or adapted so that perhaps we can build towards a vision of a health literate public health organization. And the input from you has already taken us several steps ahead. But that's something that we could think about in the long run, and that's something that the planning committee had hoped to work towards. So this has been very insightful.
So I actually was going to ask Susan to make additional comments on the 10 attributes, but I'd invite all three of you if you want to make additional comments in terms of the adaptation of the attributes of a health literate organization to public health. If, maybe starting with Susan.
Well, I'm trying to think what I actually got to say and what I sort of skipped over. I do think sort of just to reiterate some of the things, I think that attribute 10 is tough for us in Nebraska, where we're communicating clearly with health plans about what health plans cover and what individuals have to pay, because a lot of our services in Nebraska are not services for which health departments are reimbursed. And so that attribute is sometimes applicable, but often not. And I don't know, I know that because of how public health is structured, I think that would probably be something that would be difficult for other public health organizations as well. Again, highlighting language access as something that really is important in rural local public health, but also class standards in general, sort of tying those things together in a more explicit way for public health, I think is very appropriate. Health departments are really looked to by their communities as the access point for a lot of this community interaction with that would be sort of enhanced by or is driven by the practices that are called for in the class standards. So having class standards be part of the attributes going forward more explicitly, I think would be useful. Let's see. And then the navigation piece, that attribute 7, when we're talking about health information and services and navigation, I think, again, that is a very clinically, at least I understand it to be a very clinically oriented attribute, and that might not always be a good fit for public health. But I think in your case, there is more clinical services. So it's not necessarily arguing to eliminate these attributes from a discussion about public health attributes, but I do think that there needs to be perhaps more explicit wiggle room for, so that people can, so that health departments like the ones that I work with can look at the attributes and be able to see themselves and not think that it applies to other people. I think that would be the goal.
Terrific. Additional comments from either Jennifer or Torrie on the attributes in the application?
Well, I can add that they're kind of like that model idea we were talking about, is when you can hold something up that will get people engaged in discussing about where they fit. I think we could look at the attributes for the clinical end of things and apply that to public health. And there are some that won't be appropriate for clinical setting, but there might be others that aren't there that could be appropriate for public health that deal with septic systems and, other things that wouldn't be part of the clinical end. I think there's room to look at that.
Torrie?
I think to wrap up this conversation, I just want to share a little bit in saying that I spent some time in academia, had a lot of professors who did research on Appalachian populations, underserved communities, and we never really went out into those communities to understand, what they do. And that's kind of the nature of the beast when you're in academia, because you're trying to write those papers and get grants and things like that. And I and one of my professors took some time going into the Appalachian Mountains, which was totally different than what I came from in New Orleans. They have highland, we have flatland underwater. And we went out there and we studied youth who had started smoking some by the age of 5. And a lot of it is just what they have access to. And so my professor was like, wow, this is great. We need to do this more often. So I say that to say, in terms of health literacy, it's really about understanding our own biases, being aware of other people's cultural experiences, and looking at the environment that they live in as a part of how you address some of the challenges that they're experienced with. So I just leave you with not really knowing who they are or knowing who these communities are, but meeting them where they are and going into their communities, talking to them, forming trusting relationships, and not just necessarily, using them to support our research, but finding ways to sustain programs and efforts that will really help their community and cultures thrive. Excuse me.
That's very well said, Torrie. Yeah.
Thank you, Torrie. That's an introduction to my question to Susan. Monitoring the program, do you send out surveys? Do you send a service to those who provide the program, or you send it to both the people who provide the program and those who consume the program?
At this point, this project is very squarely oriented towards building capacity of the local public health departments. And so the surveys and the research that I'm doing, not research, but the evaluation pieces that we're doing are working at this point solely with the health department personnel. And yes, I think that that's a really good question because it's hard to really know how people are moving ahead without being able to go into the community and ask them questions of the community about how communication out of their public health department has improved. But right now, the scope of work that we have and the funding that we have for this particular piece doesn't really allow us to take that additional step.
But is that something you would consider, to go into the community to survey the people who use the strategies you are using? Because
I don't know that I would necessarily advocate doing a survey, but I do think that, doing research or doing evaluation and involving the community and how is it that this communication is improving, I think would be a really important step to take, yes.
Thank you.
Excellent. Other questions from anybody in the audience, from the public at this point? I know we've been taking them right along. And Drew, do we have any other questions from the internet? Okay. Any other comments you'd like to make? So at this point, I think we're at the point where we'll break for lunch. We've got an hour, approximately an hour for lunch. We'll reconvene at 1 o'clock Pacific time. We are here. I understand that lunch will be served in the refectory Roundtable members, speakers, and participants are invited to move to the end of the hall for lunch. We will begin the afternoon session promptly at about 1 o'clock then. Thank you all. Great morning. Thank this panel. Terrific panel. Thank you all very much.